Finally, the scope. Scoping is an umbrella term for putting a camera into a patient to find out what a structure looks like. So there are many different kinds of scopes. The most familiar one might be a colonoscopy, where we put a scope to look at the colon. However, upper endoscopy is looking at the esophagus, and laryngoscopy is looking at the larynx. These are all different types of scopes. Within the term scoping, there are different types of scopes we can use. There are ones to look at the larynx that go in through the nose, and one that goes in through the mouth. There's different sizes, different lights that we can use, and each piece of technology gives us different information. My personal bias, the one that I feel gets me the absolute highest resolution, highest magnification, most illuminated view of the larynx, is a scope that goes in through your mouth. That's going to look like this. It is the largest scope that we can put into the larynx, and therefore it carries the most light. It is completely painless. It goes in through your mouth. Takes about 20 seconds for most of my patients. The light that I like to use is a light called a strobe light. The strobe light will flicker in sync with the frequency of the pitch the patient is making. That allows me to view that exam in slow motion. Vocal fold vibration is just too fast for the naked eye to see. With the strobe light, I get the illusion of slow motion so I can actually watch vibration. The second most commonly used scope is the one that goes in through the nose. Unfortunately, it is the one that is relied upon the most. It is the most accessible. It's what a lot of ENTs have in their office. And yes, it does get you to the destination of the larynx. The one that I like is a distal chip, which is a microchip, so it's computer-based technology rather than fiber optic. It allows you to get some pretty good resolution, some magnification and illumination, but again, as a smaller scope, there are some limitations unless you get very, very close to the vocal cords. The advantage of using a scope like that is you can see a better assessment of the musculature of the voice. When we're using the mouth scope, I'm having to have your tongue out for that exam. That distorts how you use your voice. Now, of course, having a scope in your nose is hardly natural, but usually we get a better sense of how the muscles are engaging for voicing. So sometimes I'll actually do both scopes. I'll do the rigid, which is the oral scope, to really get vocal fold vibration and microscopic anatomy, and I'll use the flexible through the nose to understand muscular engagement. The combination of those data, plus the sound exam, plus the ENT exam, plus the storytelling, really give me a comprehensive sense of what's going on with that patient. From there, treatment planning is usually so simple and so organic because we're really able to tailor it to everything that we found.